Good evening, everyone. I welcome you all in this new episode of 4D 2.0. And we have very interesting topics lined up for next 4 or 5 sessions in which we'll be talking about diabetes and its complications. And today's topic is, I believe, one of the most important preventable complications of diabetes, and it is one of the complications that is not only associated with severe morbidity, but there is also data to suggest that it is also associated with mortality. If we talk about the number of amputations that occur, I believe the first place goes to diabetes. One disease that leads to most number of amputations, lower limb amputations, is diabetes mellitus. And today we have very renowned speaker from Mumbai who will be telling us about details of diabetic foot and how we can manage and how we can prevent this dreaded complication. So I'll welcome today Dr. Yash V. Chauhan. He is distinguished endocrinologist from Mumbai. He completed his MBBS from Rajiv Gandhi Medical College and gained internship from Chhatrapati Shivaji Maharaj Hospital. He then pursued his DNB and further MRCP from UK. He then pursued DM endocrinology from Kopiwala National Medical College, which is one of the renowned medical colleges in providing endocrine program in field of endocrinology. And then he further did specialization certificate in endocrinology from National Board. Currently, he is working as an assistant professor at his parent institute, and I believe one that would be one of proud achievements to be in the same department where he was once a student. And he's particularly interested in managing endocrine diseases like Cushing syndromes, and his particular field of interest is managing critical emergencies such as diabetic acidosis. Dr. Yash.
Thank you so much, sir. So I'll be starting with diabetes and foot complications. Can I have my slides, please? So I believe that diabetes is a silent killer. Okay, the main reason to control diabetes is because of the complications it causes, not in the next 5 years, not 10 years, probably even beyond that. And the most important and morbid condition that diabetes causes is foot disease, and let's talk about that right now. So, just a brief introduction. Around 1 in 10 Indians have diabetes. The overall prevalence of diabetes in the world above in adults aged 20 years and above is around 9.6%. And gradually, the number and the incidence of diabetes is increasing. And we're every day seeing younger and younger people with type 2 diabetes. And of course, type 1 diabetes is still there, but type 2 diabetes is what the major problem in India is right now. Um, so, like I said before, why we need to treat diabetes is because diabetes leads to complications and end organ damage, and that end organ damage is actually what leads to the major morbidities associated with diabetes. So here in the foot, prolonged hyperglycemia that results in damage to the nerves, causing peripheral neuropathy. It causes autonomic neuropathy. It affects the motor nerves. It affects the sensory nerves. It affects the blood vessels of the legs. So peripheral vascular disease, atherosclerosis, oxidative damage, and it also leads to ischemia. So that these two are the major contributory factors that it causes changes in the foot. That leads to foot ulcers. Foot ulcers often get infected, leading to high risk of sepsis because of infection and because of peripheral vascular disease. That leads to poor wound healing, and often eventually the most common cause worldwide for amputations is diabetes. Diabetic neuropathy also often leads to development of foot ulcers. One third of diabetic patients in their entire lifetime may develop a diabetic foot, and we admit a lot of patients with diabetic foot, and that leads to loss of life, loss of uh, poor quality of life, loss of their work, loss of their jobs, um, and of course a strain on healthcare. So just a quick epidemiology of foot complications. So around 11 to 14%. So this study was conducted in Maharashtra, and approximately 11 to 14% of diabetic patients here developed foot ulcers, and around 6 to 23% of foot ulcers worsen and eventually lead to amputation. So, how does this diabetic foot ulceration actually happen? So, like I said, there are three major things that are causing this diabetic foot ulceration. The first and the most important thing is hyperglycemia, and hyperglycemia, one, early control of hyperglycemia early in the disease causes, at the time of diagnosis, well controlled diabetes reduces the chance of complications later in the disease. That's something that we know as legacy effect. So of course that's one part why hyperglycemia should be prevented early in the disease itself. The other reasons are there is, even at the time of ulceration, hyperglycemia can cause uh, uh, reduced immunity, WBC malfunction, so that can lead to decreased inflammatory response, inflammation, and that leads to defective wound healing. The next two things are quite important, and both of them in conjunction are the worst reasons why diabetes can cause this foot ulcer. So, first is peripheral neuropathy. Peripheral neuropathy is in the form of somatic neuropathy or autonomic neuropathy. Somatic neuropathy leads to, it involves the motor nerves and it involves the sensory nerves. When there's motor nerve involvement, that leads to small muscle wasting, and that leads to bony deformities because of that, and that leads to something that we know as a neuropathic ulcer. A decreased because, and it also of course affects the sensations. So and that leads to altered foot pressures, and we get there are other contributory factors such as limited joint mobility, any presence of any trauma, and both these lead to neuropathic and neuroischemic ulcers. In conjunction with peripheral vascular disease, that leads to neuroischemic ulcers. Uh, Autonomic neuropathy alters the blood flow, and it can also cause decreased sweating, callus formation because of dry skin, and callus itself acts like a foreign body, and that leads to increased foot pressures and can cause ulceration. um, Peripheral artery disease uh, eventually causes ischemia to the part, and causes delayed delivery of even antibiotics, causes reduced wound healing. So this is the whole pathophysiology of a diabetic foot ulcer. So just so when someone presents with ulcer, it is quite important to classify and stage the ulcer. So these are just the couple of Wagner's classification, University of Texas classification. So these are the old ones, and they're just theoretically important. But what we actually do in clinical practice is we classify it based on infection and based on peripheral vascular disease. So it's important to classify it based on an ulcer based on these two things, because that actually gives us one, a modality of which modality of treatment we should use, and two, whether what the prognosis in terms of amputation is going to be. Obviously, there are like a few more classifications such as Sinbad classification, but let's come to the more clinically important ones. This is the IWGDF classification for an infection. When it's important to examine a wound and get as much clue of an infection as we can by examining it. So the first is, if there is no systemic signs, if we don't get any signs of infection, which I'll come to, it's an uninfected wound. At least if two of these five next things are present, such as there is purulent discharge, if there's erythema, if there's tenderness, if there's warmth, or if there is tenderness, warmth, induration, purulent discharge. So these, at least two of these five things, if they are present, it comes as a mild infection. And if any of these things extend to more than 2 centimeters beyond the wound, that's something that we classify as a moderate infection. Often we see that the infection goes a little bit deeper into the deeper tissues. There is lymphangitic streaking. There is actually get a palpable abscess sometimes. So those, if get any of those signs, they come under moderate infection. And finally, if the patient has a systemic inflammatory response that is developing fever, has a low blood pressure, has a rapid heart rate or a respiratory rate, is in sepsis basically. So that leads to a severe systemic infection. And often we find that the infection has involved the bone, and that leads to osteomyelitis. And we always add an O when we're classifying it. So this is just like the basic of classification. And when we're talking about classification from an ischemia point of view, we always use the Wi-Fi classification to portray what sort of an ischemia there is. Whenever a patient presents with an ulcer, it is extremely important to do an ankle brachial index. Ankle brachial index is calculated by the blood pressure of the lower limb compared divided by the blood pressure on the higher of the two upper limbs. And that's important to do because that gives us an idea for further investigations which we should be doing, and giving us an idea of what actually is happening with the peripheral artery, right? So here we classify it as an ankle brachial index of 0.8 to 1.3 is normal, and less than 0.4 is something that we know as critical limb ischemia. 0.4 or a severe peripheral vascular disease. Diabetic patients can also often have an ABI which can go beyond 1.3. In that case, that we always have to think about Monckeberg medial sclerosis, in which the artery walls are just thickened. So we may get a false high ankle brachial index. Coming to the next thing, so this is once the ulcer has happened, right? So now we have to classify a foot. Often patients are on regular follow-up. So how do we prevent it? The prevention happens by classifying it according to a risk classification. We stratify every patient in what risk they fall, and that gives us an idea about how to prevent further ulceration. So here this is the IWGDF classification according to the most recent guidelines. A very low risk would not have any loss of proprioception and no peripheral artery disease, and that's only on clinical examination. Then you just examine them once a year. A low risk would have either of those. A moderate risk would have both loss of proprioception and peripheral artery disease and or a foot deformity. And a very high risk patient would be someone who's already had a history of a foot ulcer, has had one amputation in the past, and end stage renal disease. These three are the most important risk factors for future ulceration. So it's important that if any of these three are present, we examine the patient every 1 to 3 months. We advise appropriate footwear, appropriate foot prevention and education to the patient. Okay, so how do we manage let's go back to how once a patient comes with a diabetic foot wound. So how would we manage? There are 5 pillars of management of a diabetic foot wound. Local ulcer care, pressure offloading is one of the most important points in a patient who has a neuropathic ulcer. Treatment of an underlying infection, treatment of a peripheral vascular disease or restoration of tissue perfusion, and metabolic control. Let me just quickly go through all these 5 points, and then we can just so the first important thing is a local ulcer care. There needs to be adequate hydration to that point, to that ulcer. We don't use betadine, so we often use hydrocolloids, and we can use debridement. So we do enzymatic debridement, we can do biological debridement. There are various modes of debridement, surgical debridement. So we often use debridase, which is like a enzymatic debridement, and we use hydrocolloids for local ulcer care. Betadine is not advised for a diabetic foot wound, it can worsen the foot. For a neuropathic ulcer, one of the cornerstones of treatment is pressure offloading. The whole in diabetic foot, the pressure, like I explained before, the entire pressures of the foot are altered, and as long as the patient keeps loading the entire body weight onto that area, a neuropathic ulcer is not going to heal. So appropriate offloading is important, and that can be done based on where the ulcer is, what location there is, if there is infection, if there is ischemia. So all those factors would apply to when deciding for offloading, what modality to use. The third thing is treatment of infection. It's important to identify what sort of infection there is. The most common organisms is usually a gram-positive coccus, but in India that we see rampant antibiotic use even for other indications. We've seen resistant organisms. We've seen because India is a tropical, subtropical country, we need to treat both gram positive as well as gram negative bacteria for this. Of course, if there is evidence of gangrene, you need to add a little bit of anaerobic cover. The treatment that we usually start with is a beta-lactam with a beta-lactamase inhibitor. And if there is, like I said, if there is gangrene, then we add a anaerobic cover. So that is one important thing that needs to be done. It's important that we also collect samples which are and send them to the laboratory for culture sensitivity and direct antibiotic against that particular organism. The next thing is peripheral vascular disease, and that's restoration of tissue perfusion. So it's this is one of the most important things that needs to be done when we're looking at peripheral vascular disease. That's when ankle brachial index comes into play. With someone who's got an absolutely normal ankle brachial index, that's 0.8 to 1.3, we can fairly well rule out a peripheral vascular disease because the sensitivity is good, but the specificity is not so good, right? So in that sense, when someone who's got an ulcer has less than 0.8, an ankle brachial index of less than 0.8, we always need to do further investigations, especially in patients who've got a large diabetic foot wound, in patients who've got non-healing wound for around 4 to 6 weeks, and that's if you're waiting for that long. If the patient has got signs of ischemia, then we often go for further investigations, which can include a Doppler, which can include a CT angiography or an MR angiography or a conventional angiography. So these are the fewer modalities for management of a diabetic foot wound. Next, I'll be talking about metabolic control and treatment of comorbidities, because this is very important. It's just sugar control is one of the cornerstones. The other things that we need to work on is blood pressure control. We need to add in patients with peripheral artery disease a low dose clopidogrel or a statin in patients with so these things do need to be done, and hypertension control also is important. Glycemic control, each patient should have their own targets, glycemic targets, and HbA1c targets put. So also another strategy that is there for diabetes management is initiation of combination therapy, where we often add DPP4 inhibitors even to patients who have an active ulcer. So it's not contraindicated. DPP4 inhibitors can be added. SGLT2 inhibitors are also can also be added once sugars are better, once we have ruled and once we have an evidence of a wound healing, once there is no infection. So these are the newer medications that can be given. Regarding SGLT2 inhibitor and DPP4 combination therapy, both of them are synergistic in their mechanism. They have different mechanisms, and therefore they give an additive reduction in your sugars. SGLT2 inhibitors increase the glycosuria, and therefore they increase the beta cell sensitivity, whereas DPP4 inhibitors increase the insulin release, and both of them reduce hyperglycemia overall. A combination therapy was well tolerated, and over 48 weeks led to improvement in body weight, and of course they're weight neutral, so that's a good thing that can be done. And DPP4 inhibitors also have a role in improvement of wound healing over 3 months, as seen in these trials. So this was just a broad overview, but this is a guide that what needs to be done when someone presents with a diabetic foot ulcer. Of course, diabetic foot is a massive topic, and I don't think I can cover it in 15 to 20 minutes. That would take probably hours at a go. Uh, so thank you for your patience and your concentration. Yeah.
Dr. Yash talk on diabetic foot. You covered the topic beautifully. You talked about pathophysiology. You talked about the risk factors. You talked about the management. We have some questions regarding diabetic foot, which we would like to discuss with you. We see a lot of patients with diabetes in our OPDs. I have a patient with diabetes who's coming to me. What should I tell him? What are the risk factors that I should look, and what precautions my patient can take so that he does not develop this complication at all?
So, in the previous slides that I had explained, like there is, whenever a patient comes to us, we need to look at the neuropathy, we need to look at the peripheral artery disease. In the neuropathy examination with a monofilament with vibration sense, or if there's vibration aesthesiometer, those options can be done. We always look at the ankle jerk or and vibration and joint position sense to look for any LOPS. Peripheral artery disease should be examined using an ankle brachial index. Risk factors that can worsen any of these, such as smoking, can worsen a peripheral artery disease. Uncontrolled blood pressure and dyslipidemia can cause peripheral artery disease. Other risk factors include end-stage renal disease, or if someone who's got a previous amputation, who's got a previous ulcer, even a previous ulcer, is these two are the major risk factors for a future amputation as well, or a future ulceration as well.
You talked about pathophysiology for diabetic foot ulcers. You talked in detail about neuropathy as well as ischemic ulcers. Are their sites different? Can I say, looking just at the site, whether this is a neuropathic ulcer or a ischemic ulcer? But most of the times we understand that it is a neuroischemic ulcer. But is there a difference in the sites of these ulcers?
Right. So when a neuropathic ulcer presents, neuropathic ulcer is basically because of like the motor as well as the sensory nerve involvement. When the motor nerves get involved, that leads to small muscle wasting, and that leads to altered pressures over the entire foot. Often there is clawing that we see, and that leads to the majority of the pressure in the first metatarsal joint of the foot. So a neuropathic ulcer is classically seen in the first metatarsal joint, um, whereas ischemic ulcers can happen anywhere on the foot, can happen on the dorsum, and can happen even on the toes. But often we see it's a combination of both. It's a neuroischemic ulcer, and it's not always possible to differentiate between neuropathic and ischemic foot.
So, are there any guidelines for screening? So, is there a difference? How frequently should I screen my type 1 vis-a-vis a type 2 diabetic patient? Are there any differences in screening?
Right. So in type 2 patients, we always screen for a patient right at the diagnosis. Uh, we at diagnosis, they already have some evidence of a neuropathy, such as there will be loss of vibration. That's the earliest sign that we often get. So we screen such patients. We end up screening based on their risk stratification according to the IWGDF guidelines that I just spoke about. Type 1 patients, we often start screening at around 5 years after their diagnosis, and then we stratify their foot, and then yearly thereafter, depending on what their risk classification is.
So, you did emphasize about glycemic control during your talk. Any specific medication that you use more commonly? So we have a lot of questions from our friends that should I always shift my patient to insulin? Is insulin absolutely required? Is it an absolute indication for starting insulin, or can I continue on with if my patient is meeting his A1C targets?
So insulin in certain cases can improve wound healing, but it's not absolutely essential. If someone is well controlled on some medications, we can continue those medications. But we often see, because they are such patients have infection, they become more insulin resistant, and there is always some need of insulin during their treatment of a diabetic foot ulcer. So it's not that an ulcer is 100% indication for insulin therapy.
So yeah, I also agree with you. Absolutely, I agree with you. So what I have seen most commonly in my practice is that if my patient has a neuroischemic ulcer which is infected, more than 99% of times he will be requiring insulin. But there are certain patients with peripheral arterial disease, those who have vascular ulcers, there they might have a well controlled diabetes, but they are still developing ulcers because of the vasculature problem, and there we may continue these patients on OHA. And it was interesting you talked about DPA4 inhibitors and their healing properties. I believe that will be helpful for our viewers. We have talked about the ulcers, but we do not want our patients to develop ulcers. So, what preventive strategies yield best outcomes in form of saving diabetic foot infections, and any specific antibiotic regimens which you prescribe?
Right. Right. So, regarding prevention of an ulcer, it is first important to stratify which classification they come in. For someone who's at a very low risk, like they don't have any loss of position sense, or they don't have peripheral artery disease on clinical examination, I usually advise off-shelf footwear. I ask them to get footwear which has adequate width for foot movement laterally. For all the toe movements laterally is easily able to accommodate all the toes. There is enough room for the great toe to move vertically. So we don't get like a footwear induced ulcer which can happen because of tight footwear. At the same time, the footwear should not be extremely loose that it slips off from the feet. I ask them for foot examination every single day with good moisturization if they're getting dry feet. They should always look for any diabetic foot, any ulcer that has developed over their soles, especially. And if they so this is just for off-shelf use, and they should go and buy their footwear in the evening. Then they should maintain nail hygiene. So these are the few things that I advise my patients. Obviously, for higher grade neuropathic, grade 2 or grade 3 of uh, a risk, we would require specialized footwear, including analysis of pressures in these patients. In patients who have already undergone previous amputation, there is no doubt that these patients require modified footwear for rest of their lives.
I believe you have partially answered my
Sorry.
next
Yeah,
question.
regarding the antibiotics,
Yeah.
usually gram-positive cocci are the ones that usually cause infection in diabetic feet, is diabetic foot ulcers. We are often we see, in fact, we right now see a lot more of gram-negative bacteria also. So it's a especially in India, we see a polymicrobial infection that is there. I usually start, like I said, with a beta lactamase inhibitor. So that can include a coamoxiclav or a piperacillin tazobactam. Piperacillin tazobactam also has some anaerobic coverage that can be of use in patients who have gangrene as well. But in patients who have gangrene and I want to give coamoxiclav, I always usually add an anaerobic cover such as clindamycin.
Regarding our next question, I believe we have already talked about footwear selection and some of the self protective practices that our patients may use. So one practice which I tell my patient, which is I believe which might not be a problem in your part of the country because it's not that chilly in Mumbai, but here in Sri Ganganagar it's really cold. We have temperatures as low as 2 degree, 3 degree. So what happens during the winters is many of our patients keep their feet in front of heaters, and I have seen at least I remember at least five of my patients who have developed deep wounds. They were not they because of loss of sensations, they were not able to perceive the burn, and they developed burn injury on their feet. So this is one thing that we usually tell our patients: do not keep your feet in front of heaters, and whenever they are taking baths, they have to get their water checked uh, from their attendant. So this is what we usually tell them in our part of the country, and I believe this is not a problem in your part because
That's it.
it's usually the same temperature all year around. You have talked about diabetic neuropathy and how to manage neuropathy so that a patient does not develop a foot ulcer. You talked about using investigations in form of vibration sensing, looking at the sensation and classifying it as a diabetic foot risk. But what precautions my patient can take in form of, if my patient has neuropathy, what should I tell my patient that yes, this is what you can do so that you do not develop a ulcer?
Right. So in patients who have a neuropathy, they often also have loss of position sense. That is what we classified them as. Uh, if they do have that, then unfortunately, what I do is they require modified footwear. They need to see. They need to examine their foot. So what I ask them is, because you often can't see the sole of your feet, take a small mirror and examine the sole of your feet
And
thoroughly, because they also have some autonomic involvement. They have dry skin, which can lead to micro abrasions and can lead to infection. They should keep their uh, legs well moisturized, but not in the crevices of their feet. So they should maintain nail hygiene, and be careful while cutting nails, because sometimes the nail cutter itself can cause ulcers and infections. So these are the few things that I always advise for someone who's got loss of position sense,
yeah,
proprioceptive sensations. Yeah,
absolutely right.
protective
So
sensations. So,
we also tell our patients to not to walk barefoot. So
and
that
that's
is another
yes, that's the
common
most
issue.
important.
And again, because of extremes of temperatures, we have even seen those ulcers, especially during summers. One of my patients was going to the temple, and there she she had to go to the temple barefoot, and she developed deep ulcers on her feet. So this is another thing that we usually tell a patient, that use some sort of socks, or just if it is too hot, do not go at a time when the floor is not that hot or cold. So this is one thing that we advise our patient. So you also talked about medical conditions such as end-stage renal transplant, and there are patients who have a combination of diabetic foot complication and an end-stage renal disease, or those who are post-organ transplant immunosuppressant. How difficult is to manage diabetic foot complications in these patients?
Right. So often, what we do is, there are certain indications for admission of a patient to a hospital. Such patients, because of their comorbidities, even if they develop a moderate sort of infected ulcer, they would require admission, because many multiple things can be managed together. What we do is, obviously they are at higher risk for infection, so you need to be a little bit aggressive in treating their infection. We need offloading. We need to So these are the few things that we need to keep in mind when treating such patients. We should always be a little bit aggressive in treating such patients.
How frequently do you use investigations like angiography, tomography, or nuclear medicine scans? And so we are using routinely. We are doing duplex ultrasonography. And how commonly do you use these investigations in your setup?
Right.
Because
This is important, especially in someone who's got an ankle brachial index of less than 0.8, because, and of course, more than 1.3. So, normal
one point.
brachial index could be 0.8 to 1.3. But if someone's got more than 1.3 or less than 0.8, we go ahead and, so if it's less than 0.4, there is no doubt that you move ahead for a higher imaging, such as a CT angiography or a conventional angiography. um, the thing is, Doppler is very subjective. In my experience, uh, Doppler is very subjective. We got reports from one examiner with showing a biphasic waveform. Someone's got like a monophasic or a or no flow. So we've got like varying degrees of reports for the same patient by different examiners. So often what we do is when a ABI is zero point 0.4 to zero point 0.8, we first do an initial screening test, because a triphasic waveform by a experienced handler of a sonography often rules out a peripheral vascular disease. Although in diabetics, the peripheral vascular disease often happens in the smaller arteries, so we are not often able to see that. But in patients who have an ABI of zero point 0.4 to zero point 0.8, it's important that if the wound is not healing for 4 to 6 weeks, if they have a big wound, if there is an infected wound, you always need to assess the vascularity, especially if a patient is planned for amputation. The extent of amputation also will change if you find a vascular disease. For example, if there is a severe peripheral vascular disease in the lower arteries, just doing a raise is not going to improve, is not probably that raise is not going to heal over time. So you may need to do a higher level. So it depends on the patient profile. So even an ABI 0.4 to zero point 0.8, in a lot of patients, we do get a CT angiography or a conventional angiography. Of course, if the Doppler is triphasic, then we don't go ahead. But that's how we usually proceed with our investigations for our patients. We sorry.
Yeah, please go ahead. Go ahead.
So we usually stratify the patient on patient to patient basis. We individualize the approach rather than just like a blanket, just do CT angio for everyone. It's not like that. We individualize approach to the patient.
So it's like you're saying, it's required in some of the patients, and uh, just a small caveat here is to look at the patient's renal status. This is for our audience, because uh, many of our patients have mild to moderate renal failure, which may progress to moderate to severe renal failure after an angiogram. So it's our habit, if we are undergoing any such procedures, we do take a nephrology consult, and we absolutely follow them, and then we go ahead with any
And
of
just
these.
in addition to that, sir, conventional angiography uses a lesser amount of contrast. So, in a few of our patients who had EGFR less than 30, but still not end stage, we've often done conventional angio without any problems with their renal function over time.
Yeah. So that's really informative, Dr. Yash, and it will help a lot of our viewers. Thank you. We have talked about everything, but I believe for healing the ulcer, we also have to look at the nutritional status of our patients. How important is nutrition and dietary intervention in preventing as well as managing diabetic foot complications? And how often do you use these micro nutrients, antioxidants? Many of our patients have anemia along with uncontrolled diabetes when they present to us. So, what is the role of looking into all of this whenever we are managing a patient with diabetic foot ulcer?
Right. So there are so I believe that diet is one of the cornerstone of management of diabetes, and like beyond, like before medications and insulin, like there needs to be some diet modification happening to every patient that presents with to our clinic for diabetes control. So often what we see is uh, our Indian diet has a lot of carbohydrates. It's just full of carbohydrates and saturated fats. So we always modify the diet a little bit. Of course, the proportion of proteins, carbohydrates, fats is not optimally known, but what we usually do is we increase the protein intake a bit. We reduce their simple carbohydrates, no added sugars. We avoid fructose like fruits, simple fruits, and absorbable sugars. We avoid such a diet. We avoid polyunsaturated fatty acids in diet. We So this is just the basic of diet that we advise. We give them like a kilocalories. Set up kilocalorie target for each patient depending on their activity, what they have, and we advise them treatment based on that, and we advise them diets based on that. Now, regarding the micronutrients, it is very important, especially like you said, sir, anemia. Anemia is an important risk factor for an infected wound not healing. So all these factors do play a role. We look at anemia. Anemia can be of chronic diseases. It can be an iron deficiency anemia in a patient with a kidney problem as well. So it's important that we correct all the factors underlying deficiencies prior to uh, in a patient with a non-healing wound, especially.
I absolutely agree with you. How frequently do you advise regarding this? Because there are lots of videos now coming about protein deficiency, and many of our patients are on protein supplements. How frequently do you advise, not only in diabetic foot ulcers but also in your diabetic patient? How frequently do you advise them on protein supplements?
So there is evidence that protein early in the day leads to improved glycemic control throughout the remainder of the days. What I advise my patients, especially we have this side of the country, we have a lot of vegetarian patients and vegetarian diet is especially low in proteins. So we often give them some protein supplements either in the morning, or we give them a protein rich breakfast followed by divided proteins in the day. So we increase the protein content a little bit, considering our diet is majorly made of carbohydrates and fats. So that's how we usually do it. Maybe like the legumes and sprouts and all those things, which can improve soya containing products, which patients can palate and they could probably have for their breakfast, or you can give them protein supplements prior to breakfast.
Yeah, thank you, Dr. Yash. It was great listening to you and talking to you about on diabetic foot ulcers. We learned a lot from you today. Any last message for our viewers on diabetic foot?
So it's important that we examine the foot at the first visit for every patient. We often look at everything else. We look at medications, insulin, diet, etc., etc. But foot is something that is ignored and is actually one of the most morbid things in diabetes. One of the most morbid complications of diabetes is the diabetic foot. So we need to always examine a patient at the first visit, grade them, and follow them up based on that.
Yeah, that was I believe one of the most important messages that you gave, that do look at the foot on first visit itself, because if you give that the foot that amount of importance, your patient will also take care of his foot, and this will prevent a lot of foot ulcer complications if the disease. Thank you, Dr. Yash, again for a very insightful talk. It was a pleasure having you here on this show. And with that, I believe we have come to the end of a very interesting session today. We'll be again back with you in a week or so with another interesting topic. Thank you from my side. Thank you.
Thank you.